Hello, everyone. Thank you for the introduction. Thank you for having me. I'm a genitourinary oncologist at Stanford in the Palo Alto VA, and today I'm going to review the updates from GU ASCO, which took place, of course, in February of this year. For the sake of time, we'll have time for 6 presentations, 2 for prostate, 2 for kidney, and 2 for bladder. This year at GU ASCO, I would say we saw a number of studies that were practice influencing, certainly updates from studies we had seen previously that influenced how we choose therapy. So starting with prostate, first, we'll talk about TALAPRO-2, which was a study of talazoparib and enzalutamide in all comers with metastatic castrate-resistant prostate cancer. So for a little bit of background, we know that we see HR mutations in prostate cancer. It's been seen in about 10% of patients with germline mutations, and more than 20% of patients are generally found to have somatic mutations in DNA repair genes. And this is important because it's led to the use of PARP inhibitors in prostate cancer. For many years, we've been using olaparib for prostate cancer as a single agent. However, synergy between PARP inhibition and AHAR inhibition is thought to be important. And so it's been seen that AHAR inhibition potentially increases double-stranded DNA breaks, which might potentially augment the benefit of PARP inhibitors. And so there's a lot of interest in combining these agents. In the recent years, we've seen 3 main randomized controlled clinical trials: Magnitude, Propel, and then TALAPRO, which is the one that we'll be discussing today and was presented at GU ASCO. And so the TALAPRO design was TALAPRO plus enzalutamide versus enzalutamide alone in first-line metastatic castrate-resistant prostate cancer. And notably, these patients were allowed to have had prior abiraterone or docetaxel for hormone-sensitive prostate cancer. And this was an all-comer study, so unselected cohort. Patients did or did not have HR gene alterations, or that HR status was unknown. A primary outcome we had previously seen was progression-free survival, and the data presented at GU ASCO was overall survival. So the majority of these patients had bone or lymph node-only disease, with about 10 to 15% with visceral disease. And also notable is that despite being allowed to have had prior abiraterone exposure, only 5 to 6% of these patients had this, and about 20% of these patients had docetaxel. As you know, the study was started many, many years ago, which is why it influenced these baseline characteristics. In terms of the type HR mutations that we're seeing, about 20% of patients on both arms had HR mutations, CDK12, BRCA2, ATM being most common, followed by others. And then the update on the progression-free survival was significant, with a median progression-free survival of 33.1 months with talazoparib plus enzalutamide versus 19.5 months with enzalutamide alone, so about a 13.6-month improvement in PFS in the updated data. And then what we saw was that overall survival was significant in all comers. And so there was about an 8.8-month improvement in median overall survival with the combination of talazoparib plus enzalutamide. And so I think it's important to then look at the AEs that we're seeing. And so there is, with the combination, a significantly increased risk of cytopenias. That includes anemia. And 8.8% of patients discontinued talazoparib due to anemia, 42.2% received blood transfusions. And so this is a significant toxicity of the combination, along with neutropenia and thrombocytopenia that we can manage. And then while this was a positive study for overall survival in all comers, it's really important to look at the genomic data. And so highlighted in this forest plot, you see the HRR status, which in the deficient patients, the hazard ratio was 0.42 with a confidence interval of 0.36 to 0.81, so quite significant in HR deficient patients, versus in the non-deficient and unknown patients in cohort 1, the hazard ratio is 0.874 and the confidence interval crosses 1. So at the same meeting, there was also a poster presentation by Dr. Fazazi looking at cohort 2, which were the HRR known patients. And so these curves on the right, I apologize, are a little bit blurry, but I'll point out the first curve is the HRR altered patients. And so you can see that there is a significant benefit for HRR altered. The second curves are the BRCA1 and 2 patients. And so you can see that the benefit is quite more significant. Those curves separate versus the last curve, which is the HR non-altered patients. And so in this other analysis of the same clinical trial, cohort 2, you can see that clearly gene and genomics do matter, and the greatest benefit is in the BRCA2 altered patients for this combination. So this table is a table of all of the current FDA-approved PARP inhibitor regimens for metastatic castrate-resistant prostate cancer. So you can see olaparib and rucaparib monotherapy, which we've been using for many years, and then the 3 combinations that have been recently studied in clinical trials. I want to highlight the indication for talazoparib and enzalutamide remains HR gene mutated castrate-resistant prostate cancer. And so this year, the FDA ruled against expanding the label to all comers based on this data. So what we can say from TALAPRO-2 is that talazoparib and enzalutamide improve both radiographic progression-free survival and overall survival for first-line metastatic castrate-resistant prostate cancer. And this benefit really is seen greatest in the BRCA1 and 2 mutated patients, HRR mutated patients followed by non-HRR. And the combination therapy does result in increased grade 3 cytopenia, specifically anemia, requiring transfusions. And I think one major limitation that we pointed out is that only about 5% of patients had prior abiraterone. So how we can apply this data to our real-world practice is a little bit challenging in that this is a population we rarely see. Most of our patients are getting abiraterone or an ARPI in the first line in hormone-sensitive disease. And so data from hormone-sensitive prostate cancer is important. While this wasn't from GU ASCO, it was presented at ASCO this year, which is the first study of a PARP inhibitor and an androgen receptor pathway inhibitor in hormone-sensitive prostate cancer. And what we saw was that there was a radiographic progression-free survival benefit, and overall survival remains immature. I think there's still a lot more to come from this data, and other studies that are ongoing in metastatic hormone-sensitive prostate cancer. So switching gears to another study in prostate cancer that was presented, which was the STOP-CAP meta-analysis. And so this was a meta-analysis of 7 different clinical trials that was looking at patients with metastatic hormone-sensitive prostate cancer and assessing the benefit that they get from intensification with androgen receptor pathway inhibitors. And so we know that there's been multiple randomized controlled trials that have shown a benefit of adding an androgen receptor pathway inhibitor to ADT. And the question is, do the side effects vary between the different inhibitors and based on patient disease and characteristics? And so in this meta-analysis, they took individual patient data from 7 completed randomized controlled trials. And so these are the trials that they looked at. The majority, as you can see, included patients with synchronous metastases, about half with high volume disease, with the exception of latitude, the median age of 60, and some of these trials included docetaxel as part of standard of care. And what the STOP-CAP meta-analysis showed is that there really is a clear benefit, of course, of adding androgen receptor pathway inhibitors to overall survival. It showed about a 13% improvement in overall survival at 5 years and about a 21% improvement in progression-free survival at 5 years. And they did not find in the analysis a clear difference based on class of agent. And then of note in this analysis, they only had about 48% of the amide data. So that's enzalutamide, apalutamide, and darolutamide versus 100% of the abiraterone data. And then something that they found that was very interesting was when they broke up the groups based on age, so age less than 65, age 65 to 75, and then greater than 65, there was a signal that there was not a survival benefit with the addition of abiraterone in the older age groups, so age greater than 75. And then when they looked at prostate cancer-specific survival, that signal was dimmed in that suggesting potentially there could be an impact of abiraterone on other comorbidities and other reasons for the survival benefit. And when they looked at the amides, so enzalutamide, darolutamide, or apalutamide, they did not see this signal. And so this is a notable finding from the STOPCAP meta-analysis suggesting a difference between abiraterone versus an amide in our older patients. And so what we can say is that there is a clear benefit of intensification with androgen receptor pathway inhibitors to overall survival across 7 different randomized controlled trials for metastatic hormone-sensitive prostate cancer. And then in our patients age greater than 75, you might consider amides and the potential risks of abiraterone based on their comorbidities. So switching gears from prostate cancer to kidney cancer, we're going to first review COSMIC-313, which was a study of triplet therapy and metastatic renal cell carcinoma. So as you know, we have a number of first-line combinations available for metastatic RCC based on prior randomized controlled clinical trials that compared nivolumab and ipilimumab, axitinib, pembrolizumab, cabozantinib with nivolumab, and lenvatinib with pembrolizumab against sunitinib. COSMIC-313 was notably the first study of triplet, and the comparison arm was nivolumab and ipilimumab. And so it included patients with specifically IMDC poor or intermediate risk, advanced renal cell carcinoma, and randomized them to cabozantinib with nivolumab and ipilimumab versus nivolumab and ipilimumab alone. You can see that majority of the patients in COSMIC-313 were intermediate risk, about 75%, with about 25% poor risk, with lung, lymph node metastases being more common than bone and liver. And what we saw at GU ASCO was the updated progression-free survival benefit, which we'd previously seen. However, you can see that hazard ratio is higher and the confidence interval that nearly approaches 1 in the intention to treat population. And what we saw then was that the overall survival was actually not significant with triplet versus ipilimumab and nivolumab in the intention to treat population. When you break down the data based on IMDC risk group, so intermediate versus poor risk, there actually was still a maintained progression-free survival benefit in the intermediate risk group with cabozantinib, nivolumab, and ipilimumab. However, that was not seen in the poor risk group, and overall survival was not significant in either risk group with triplet therapy. And so this was interesting and important to think about why these patients may not benefit from triplet therapy. And one key finding was that there was a high rate of treatment-related AEs that led to discontinuation of therapy in the triplet arm. So about 49% versus 26% with ipi-nivo alone. And so may this contribute potentially to the efficacy of triplet. They saw higher rates of liver toxicity, diarrhea, rash, endocrinopathies, and so what we can say about COSMIC-313 is that triplet, so cabozantinib, ipilimumab, and nivolumab, did improve progression-free survival, but there was actually no difference in overall survival compared to ipilimumab and nivolumab. And so I would say that the PFS advantage that we saw with intermediate risk disease was unexpected relative to the poor risk group. And I do commend the use of a modern comparator arm compared to prior studies of ipi-nivo, but I think we can say that the high rates of adverse events may limit drug exposure and potentially efficacy of the use of triplet therapy in metastatic renal cell carcinoma. So the next study that we'll look at was Checkmate 9er. So this is one that we had seen before, another combination for metastatic renal cell carcinoma of nivolumab and cabozantinib, and the updated data that was presented at GU ASCO. This study included patients with clear cell metastatic RCC and any IMDC risk groups, including favorable, intermediate, and poor risk disease, randomized patients to nivolumab plus cabozantinib versus sunitinib. And you can see here that, here we are. The majority of patients were intermediate risk, but about 20% of favorable and poor risk patients. And they did allow for sarcomatoid features. And so this is the updated progression-free survival benefit. You can see it's quite significant in the intention to treat population with nivolumab and cabozantinib versus sunitinib, and in addition to the overall survival benefit of nivolumab plus cabozantinib versus sunitinib in the intention to treat population. When you look at the data based on risk groups, specifically in the favorable risk group, what was seen was that there was a progression-free survival benefit. However, there was not an overall survival benefit in this risk group. So I think that is notable in how we implement this data into practice. And what we can say is that cabozantinib plus nivolumab does continue to improve overall survival, and progression-free survival over sunitinib is a good option for us in metastatic RCC. However, the favorable risk population, they did not show an overall survival benefit, so you might reach for your other combination regimens for this group of patients. Okay, and then switching gears to urothelial cancer. We'll speak mainly to sort of the perioperative management of muscle-invasive bladder cancer, starting with Checkmate 274, which was a study of adjuvant nivolumab for high-risk muscle-invasive urothelial cancer. This was a randomized clinical trial of patients with muscle-invasive bladder cancer who did or did not have neoadjuvant chemotherapy, and were randomized to 1 year of adjuvant nivolumab versus placebo. And patients were stratified based on PD-L1 status, in addition to having had prior neoadjuvant chemotherapy. And in terms of the patient characteristics in this clinical trial, it did include upper tract urothelial cancer, including renal, pelvis, and ureter in about 20% of the patients. And about half of the patients had gotten neoadjuvant cisplatin-based chemotherapy. And about half of the patients were node positive in this clinical trial. And what we saw was that in terms of disease-free survival, there was a significant benefit with the addition of adjuvant nivolumab for patients with muscle-invasive bladder cancer, 25.6 months versus 8.5 months. And what we saw at GU ASCO was that there actually also was an overall survival benefit with the use of adjuvant nivolumab. We might say that it's important in an adjuvant study to look for an overall survival benefit, especially now with our first-line metastatic options, including enfortumab and pembrolizumab and other immunotherapy. So this was notable data suggesting the benefit of nivolumab in the adjuvant setting for these patients. When they looked at this benefit based on having had prior neoadjuvant chemotherapy versus not having had prior neoadjuvant chemotherapy, the benefit was maintained in both of those groups. One thing that was notable is on the force plot you can see here, our upper tract patients, which are high risk, may not have as much of a benefit, but suggesting that does adjuvant nivolumab mitigate the risk of this already high risk population. They also presented the data on PD-L1 positive patients, and you can see that the benefit of adjuvant nivolumab was really enriched in PD-L1 patients who were positive across all endpoints, nearly doubling the disease-free survival in PD-L1 greater than 1% from 22 months to 52.6 months. And so what we can say from Checkmate 274 is that adjuvant nivolumab does continue to show a disease-free survival benefit, but now also an overall survival benefit. PD-L1 appears to increase that benefit, and there's a lot of interest in understanding how we can better predict patients who will benefit from adjuvant therapy, knowing that there is a significant proportion of patients who will be cured by cystectomy. How can we decide who to offer adjuvant therapy to? So in prior data from IMvigor10, we saw ctDNA as an important marker to help predict overall survival in these patients and the benefit of adjuvant immunotherapy of atezolizumab. In this study, we're seeing PD-L1 as a potential predictor of benefit from adjuvant immunotherapy. And ongoing, of course, this needs to be studied prospectively as a modern clinical trial. It's a cooperative group trial that's actually looking at patients post-cystectomy and ctDNA status, and though asking the question of, does adding immunotherapy in addition to relatlimab improve overall survival in the ctDNA positive patients, and then also asking the important question of, does nivolumab provide any benefit in ctDNA negative patients? And so I think this trial will inform this decision even more. And then moving on to another study of muscle-invasive bladder cancer and perioperative therapy, which is Niagara. And so we saw some updates at GU ASCO this year from this clinical trial, which was really studying a sandwich regimen of durvalumab plus gemcitabine and cisplatin with adjuvant durvalumab versus gem-cis alone in the neoadjuvant setting. And so it included patients with cisplatin-eligible muscle-invasive bladder cancer, and key endpoints that were presented included pathologic complete response rate in addition to metastases-free survival and disease-free survival. And so what we saw from the presentation on Niagara was that the addition of perioperative durvalumab to cisplatin and gemcitabine did improve both metastases-free survival and disease-free survival for these patients. And there was about a 10% improvement in pathologic complete response rate in the patients who got durvalumab in the neoadjuvant setting. It was important to look at those who had a pathological complete response versus non-pathological complete response, and the benefit of durvalumab was maintained, as you can see on the light blue curves with the probability of survival. And so what we can say from Niagara is that perioperative durvalumab did improve pathologic complete response rate. We also saw a metastases-free survival benefit versus gemcitabine and cisplatin. And whether or not patients had a pathologic complete response, the addition of durvalumab showed a trend towards overall survival benefit. I would say that one limitation is that currently in the neoadjuvant setting, we've increased the use of dose-dense MVAC over gemcitabine and cisplatin per Vesper, and so it remains unknown the contribution of, so that's a criticism essentially of the comparison arm, and it also remains unknown the contribution of neoadjuvant versus adjuvant immunotherapy. And so, in current practice, I think we have two main options for muscle-invasive bladder cancer. For patients that are fit and able to get dose-dense MVAC, we might consider neoadjuvant dose-dense MVAC, and in those who have YPT2 disease at surgery, they may benefit from adjuvant nivolumab or enrolling in the modern clinical trial. This will avoid overtreatment with immunotherapy toxicity in those who don't have residual disease YPP2 versus the sandwich approach, which would be neoadjuvant gem-cis plus durvalumab with durvalumab for 1 year following. If those patients are getting gem-cis and durvalumab following, it may benefit the 10% of patients who don't have YPT2 disease but do develop metastases and would not have qualified for adjuvant nivolumab. So that was sort of a whirlwind of 3 diseases, and some of the data we saw from GU ASCO. I think we have some time for questions and would welcome anybody.
If there are no questions, we can thank Dr. Parikh for her excellent presentation.